Most people believe that more medical testing is always better, that more screening means more safety, that finding something early is always the right move. That belief is understandable. It's what we've been taught, and for many tests at many ages it is absolutely true. But after 70 something shifts, and the shift is not subtle. The same screening tests that protect a 55-year-old can, in certain circumstances, trigger a cascade of procedures in a 75-year-old that causes more harm than the condition they were looking for. Not because the tests are bad, not because the doctors ordering them are wrong, but because the math of benefit and risk changes as we age, and most patients are never told that the math has changed. The U.S. Preventive Services Task Force, the independent body of physicians and scientists that evaluates evidence on preventive care, has published guidance suggesting that several routine screening tests commonly performed in older adults either provide diminishing benefit, carry increasing procedural risk, or both after certain age thresholds. These recommendations are not fringe opinions. They are evidence-based conclusions from some of the most rigorous medical review panels in the country. And yet most patients over 70 are still receiving these tests automatically, without a personalized conversation about whether the benefit still outweighs the risk for them specifically. My name is Dr. William Parker. I have spent 21 years specializing in senior health, and today I want to have that conversation with you. I am going to walk you through 5 screening tests that deserve a more careful, personalized discussion after age 70. What the evidence actually shows, what the risks are, and what questions you should be asking your physician before you agree to them automatically. I want to be clear about something before we begin. This is not a video telling you to refuse medical care. It is a video about informed consent, about your right to understand what a test is actually likely to do for you, specifically at your age, with your health history, before you agree to it. That is a right every patient has, and it is one that too few people exercise. Stay with me through all 5. Screening number 4 is the one most people never question, and it is the one where the gap between perceived benefit and actual benefit is widest for older adults. And screening number 5 reframes the entire conversation about what preventive medicine after 70 should actually be for. If this channel is new to you, subscribe now. This is what we do here. Calm, evidence-based guidance for adults who want to understand their healthcare, not just receive it. Let's get into it. Before I walk you through the 5 screenings, I need to give you one framework. Without it, the individual examples won't connect into a principle you can use. I call it the age-shifted calculus, and it changes how you think about every medical recommendation you receive after 70. 3 things change about the benefit-risk calculation for screening tests as we age. First, the lead time shrinks. Screening tests find things early so that treatment can begin while there is still time to meaningfully change the outcome. At 55, finding a slow-growing cancer early might add 15 or 20 years of healthy life. At 78, the same early detection might add months or in some cases produce no survival benefit at all, while still exposing the patient to the anxiety, procedures, and complications that follow a positive result. The lead time that makes screening valuable compresses significantly after a certain age. Second, procedural risk rises. A colonoscopy in a healthy 55-year-old carries very low complication rates. The same procedure in a 78-year-old on multiple medications with reduced kidney function and age-related changes in bowel wall tissue carries a meaningfully different risk profile. The procedure didn't change, the patient did. Third, and this is the one most patients never hear clearly stated, the cascade effect becomes more dangerous. One positive test almost never ends the conversation. It begins one test leads to a follow-up. A follow-up leads to a biopsy. A biopsy leads to a treatment decision. At each step, a person who walked in feeling completely fine is now managing risk, side effects, anxiety, and complications from a process that may have been triggered by finding something that was never going to harm them. The older the patient, the harder the body recovers from each step in that cascade. That is the age-shifted calculus. It is the filter for everything that follows. Keep it with you. I want to ask you something. Think back to the last time you left a routine appointment with a new test ordered. Did you ask why? Did you ask what would happen if the result came back abnormal and what the step after that would be? Most people don't, not because they're passive, but because they trust the system. And for most of their lives, that trust has been well placed. But at some point in the 70s, the automatic checklist that was protected at 60 deserves a different kind of conversation. Not suspicion, just a more personalized one. If you've ever had a test lead to another test or a finding lead to a procedure and quietly wondered afterward whether all of it was necessary, this video was made for you. Here is what I want you to hold on to. Questioning a screening test is not the same as refusing medical care. Asking your physician, why is this right for me specifically at my age, is one of the most medically responsible things you can do. It leads to better conversations, more personalized decisions, and in many cases, better outcomes. Before we go deeper, if you want a written guide that helps you organize these conversations, my free longevity guide is linked in the description below. Grab it now and follow along. Let me explain the mechanism that makes the cascade effect specifically risky for older adults, because once you see it clearly, each of the 5 screenings will make immediate sense. Picture a single pebble dropped into still water. It creates rings that spread outward, each one a consequence of the first impact. In medicine, a positive screening result is that pebble. The rings are the subsequent tests, procedures, and treatment decisions that follow almost automatically. For a younger, healthier patient, those rings spread across calm water. Each one is manageable. The body recovers between them. The kidneys, the cardiovascular system, the immune response, they absorb the stress of procedures and bounce back. For an older patient managing multiple chronic conditions, taking multiple medications with age-related changes in organ function and healing capacity, the water is not as calm. The rings interact. A biopsy requiring anesthesia interacts with kidney function. A new medication started after a finding interacts with medications already being taken. A period of restricted activity following a procedure accelerates the muscle loss in someone already at the margin. This is not a reason to avoid all medical intervention. It is a reason to be deliberate about which pebble you drop and when. The American Board of Internal Medicine's Choosing Wisely initiative, in which dozens of specialty organizations have published recommendations about tests and treatments that are commonly ordered but not always necessary, includes multiple screening tests in its guidance for older adults. The unifying principle, the value of any medical intervention must be weighed against its burden, and that calculation is individual, not universal. Now, the 5 screenings, I have ordered them from common and frequently misunderstood to most significant because the final one reframes everything else on the list. Screening 1, routine colonoscopy after age 75. Leonard was 77. He had been having colonoscopies every 10 years since he turned 50. His most recent one, 3 years earlier, was completely clean. His internist ordered another one as routine. Leonard didn't question it. He assumed it was still the right thing. He went in for the bowel preparation the day before. The large volume of laxative solution required caused a significant electrolyte imbalance, and Leonard ended up in the emergency room for 2 days before the procedure even happened. Most people think of colonoscopy as low risk. For most adults under 70, that is largely accurate. For adults over 75, the risk profile is different in 3 specific ways. The bowel preparation involves large volumes of liquid and powerful laxatives over 24 hours. In younger patients, the dehydration and electrolyte shifts this causes are minor and self-correcting. In older patients, particularly those on diuretics, blood pressure medications, or with any degree of kidney impairment, these shifts can be clinically significant. The sedation required for the procedure carries elevated risk in patients with cardiovascular or pulmonary conditions, and the bowel wall itself becomes thinner and more fragile with age, increasing the risk of perforation during the scope. The U.S. Preventive Services Task Force recommends that colorectal cancer screening continue through age 75 for most patients, that the decision to screen between ages 76 and 85 be individualized, and that after age 85, the harms of screening likely outweigh the benefits. Research published in JAMA Internal Medicine found that among adults aged 70 and older with a prior colonoscopy, the probability of developing colorectal cancer within 10 years was low, while the procedural complication rate was not negligible. The practical guidance: if you are over 75, have had a recent clean colonoscopy, and are being scheduled for another one automatically, ask your physician specifically, given my age, my prior screening history, and my current health, what is the specific benefit I am likely to get from this procedure? And how does that compare to the preparation and procedural risks for someone my age? That is not a refusal. It is a request for individualized reasoning, and you are fully entitled to it. The common mistake is assuming that because a test has always been ordered, it still carries the same rationale it always did. The test didn't change, your circumstances did. The next screening involves a more emotionally charged question, because the word cancer changes how most people think about risk. Screening 2, aggressive cancer screening, mammograms and PSA prostate testing after age 75. Alice was 76. She had been getting annual mammograms since her early 50s. Her most recent one showed a small finding that required further imaging. That imaging led to a biopsy. The biopsy found a very small, slow-growing tumor. She underwent a lumpectomy followed by 6 weeks of radiation. The recovery was long and hard. A year later, her oncologist mentioned that the tumor had features suggesting it was so slow-growing that it likely would never have caused symptoms or affected her lifespan. But once it was found, the medical and emotional momentum of the cascade had made stopping at any step feel unthinkable. The concept at the center of this conversation is called overdiagnosis, finding a cancer that would never have become clinically significant during the patient's remaining lifetime. This is not a theoretical concern. It is a documented phenomenon in cancer screening literature, and its frequency increases with age because slower growing cancers make up a larger proportion of findings in older patients and competing causes of death become more relevant. The U.S. Preventive Services Task Force recommends that mammography screening decisions in women 75 and older be individualized, citing insufficient evidence that continued screening benefits this age group while acknowledging documented harms from false positives and overtreatment. For PSA prostate cancer screening, the task force recommends against routine screening in men 70 and older, citing evidence that the harms of detection and treatment, including incontinence, erectile dysfunction, and cardiovascular effects from some hormonal treatments, outweigh the benefits for most men in this age group. A major analysis published in the New England Journal of Medicine estimated that among men diagnosed with prostate cancer through PSA screening, a substantial proportion had cancers that would never have caused symptoms or death, but the treatments those men received caused real, lasting harm. The practical guidance, if you are being scheduled for routine mammography over age 75, or if a PSA test is being ordered as part of your annual panel, ask your physician, given my age and overall health, what is the realistic benefit of finding something through this test, and what would the treatment path actually look like for the most likely finding? The answer to that second question is the one most people never receive before agreeing to the test. The common mistake is equating detection with protection. Finding something is only protective when acting on it meaningfully improves your quality or length of life. At 75 and beyond, that equation requires a specific answer for your specific situation. Quick pause. Has a physician ever had a specific conversation with you about whether a routine screening was still appropriate for your age, or has it simply always been scheduled as part of your annual visit? Drop a yes or no in the comments. This conversation is rarer than it should be, and the people in this community deserve to know they're not alone in never having had it. Screening 3. Routine cardiac stress testing in people without symptoms. George was 73. He felt completely well. His annual executive health panel included a cardiac stress test as it always had. The test showed an abnormality. He was referred for a cardiac catheterization. The catheterization found a narrowing in one coronary artery. He was placed on a stent. He experienced a complication at the vascular access site and required an additional hospitalization. Several years later, his cardiologist acknowledged that given his complete absence of symptoms, The evidence suggested that optimal medical management alone without the procedure would have achieved the same cardiovascular outcome while avoiding the procedural risk entirely. The ischemia trial, published in the New England Journal of Medicine in 2020, followed over 5,000 patients with moderate to severe coronary artery disease and found that an initial invasive strategy, stenting or bypass surgery, did not reduce the risk of heart attack or death compared to optimal medical management alone in patients who were clinically stable and without significant symptoms. For stable asymptomatic patients, the cascade triggered by finding a blockage did not produce better outcomes than careful medical therapy, but it did produce procedural risk. In asymptomatic older adults, routine stress testing follows exactly this cascade pattern. An abnormal result leads almost automatically to catheterization. Catheterization often leads to intervention. An intervention in an older patient carries risks: contrast-induced kidney injury, bleeding, arrhythmia, vascular complications that in a symptomatic patient may be clearly justified by clinical need, but in an asymptomatic patient require much more careful individual consideration. The practical guidance: if you feel well, have no chest pain, no significant shortness of breath with ordinary activity, and are being scheduled for a routine cardiac stress test without a specific clinical reason, ask your physician what specific symptom or finding is this test designed to investigate, and what would we do differently if the result is abnormal versus normal. If the answer is it's just routine, that is the right moment to ask for a more specific justification tied to your individual situation. The common mistake is assuming that a test recommended by a physician has already been individualized. In busy clinical settings, standard protocols often drive test ordering more than individualized patient assessment does. Asking for the reasoning is not challenging the physician's judgment. It is inviting a better conversation. I want to shift focus now. What comes next is where the age-shifted calculus applies most directly to daily quality of life, and where I have seen the most significant gap between what patients are told and what the evidence actually shows. Screening for routine bone density DEXA scans and automatic osteoporosis treatment initiation in adults over 80. The fear driving this screening is entirely legitimate. Hip fractures in older adults are serious. They carry real risks of functional decline, hospitalization complications, and in some cases significant mortality. The desire to protect against them is completely reasonable. What is worth examining carefully is whether the automatic pathway from low DEXA score to medication initiation achieves what patients and families hope it achieves, particularly in the very elderly. Margaret was 82. Her DEXA scan showed low bone density. She was started on a bisphosphonate medication and took it faithfully for 5 years, experiencing persistent gastrointestinal side effects throughout. During a later consultation, her physician noted that the evidence for bisphosphonate benefit in women over 80 is considerably weaker than the evidence in women in their 60s, and that fall prevention interventions, removing rugs and tripping hazards at home, balance and strength training, medication review for drugs that increase fall risk, and vision correction had strong, consistent evidence for reducing fracture rates at any age and carried no medication side effects whatsoever. These interventions had never been offered to Margaret as a primary strategy. The distinction the research supports is clear. In adults under 70 to 75 with osteoporosis, medication to increase bone density has solid evidence of fracture risk reduction. In adults over 80, the evidence thins, and multiple professional guidelines, including guidance from the American Geriatric Society, note that the benefit-risk calculation is less clear, particularly for patients who are frail, managing multiple medications, or who have had prior fractures. Meanwhile, fall prevention interventions have consistent, well-documented evidence at every age and carry none of the medication burden. The practical guidance, if you are over 78 and being started on osteoporosis medication following a DEXA scan, or if you have been on such medication for several years, ask your physician, what is the specific evidence for this medication reducing fracture risk for someone my age, and have we fully addressed the fall prevention factors that are equally or more important? Both conversations belong in the room. Most of the time, only one of them happens. The common mistake is treating the bone density number as the only relevant variable. It is a data point. The right treatment decision requires context, your age, your functional status, your medication burden, your fall history, and what you want your daily life to look like. Now here it is, the screening that most completely illustrates everything I have been building toward, and the one that carries the most significant procedural risk when the cascade it triggers goes wrong. Screening 5. Carotid artery ultrasound in people without any neurological symptoms. I want to be precise here because this screening has an important and appropriate use, and I want to distinguish that from the context we're discussing today. When a patient has experienced a TIA, a transient ischemic attack, the kind of warning event we covered in a prior video, or any neurological symptoms suggesting reduced blood flow to the brain, imaging the carotid arteries is a critical and clearly indicated step. That is not what we're discussing. What we are discussing is routine carotid ultrasound screening in older adults with no neurological symptoms whatsoever. Simply a screening test included in a cardiovascular panel, or offered at a community health screening event, or part of a comprehensive preventive workup. Richard was 74. He felt completely well. His physician mentioned that given his age and cardiovascular risk factors, a carotid ultrasound might be worthwhile. The ultrasound found a significant narrowing of about 70% on one side. He was referred to a vascular surgeon. Surgery was recommended. Richard elected to proceed. During the carotid endarterectomy, a surgical procedure to remove the buildup from the artery wall, he had a stroke. The procedure intended to prevent a stroke caused one. This is not an extreme outlier. The stroke risk of carotid endarterectomy in asymptomatic patients runs in the range of 2 to 3% across published surgical literature. For a patient who is symptomatic, who has already had a TIA from that artery, that procedural risk may be clearly justified by the risk the untreated stenosis poses. For a patient with no symptoms, the justification requires much more careful examination. The U.S. Preventive Services Task Force currently recommends against screening for asymptomatic carotid artery stenosis in the general adult population, concluding that the harms driven primarily by the cascade following a positive result outweigh the benefits for people with no neurological symptoms. Research from the Veterans Affairs Cooperative Studies Program found that while surgery reduced stroke risk in selected asymptomatic patients over several years, the absolute benefit was modest, and the patients who benefited most were younger, healthier, and at lower procedural risk, a profile that often does not describe the patients being offered this screening at 75 or 80. What the evidence does support at any age and for any degree of carotid artery disease is optimal medical management, well-controlled blood pressure, lipid management, antiplatelet therapy where appropriate, and the lifestyle factors that reduce cardiovascular risk across the board. Multiple recent trials have found that optimal medical therapy achieves outcomes that approach or equal surgical intervention for asymptomatic patients without the procedural stroke risk. The practical guidance if a carotid ultrasound finding is presented to you and surgery is raised as an option, ask 3 specific questions before proceeding. First, what is my annual stroke risk from this finding based on current evidence, and how does that compare to the procedural stroke risk at this center? Second, what does optimal medical management look like as an alternative to surgery, and what would that involve specifically? Third, am I a candidate who the evidence suggests benefits from surgery, or am I in a group where the benefit over medical management is less clear? Those 3 questions reframe the conversation from automatic cascade to informed individual decision. That is exactly where it belongs. The common mistake, and it is the most consequential one on today's entire list, is treating the discovery of a finding as automatic justification for the intervention that follows. It is not. A finding requires evaluation. Evaluation requires context, and context requires a physician willing to walk through the evidence with you, not just the referral pathway. Before your 30-day action step, here is a tool for your next appointment. I call it the Screening Value Clarity Protocol. 5 questions, write them down. They apply to any screening, but are especially valuable for the 5 we covered today. Question 1. What specific benefit am I likely to get from this screening at my age and with my health history compared to the general population this test was originally designed for? Question 2. If this test comes back abnormal, what is the next step and what is the step after that? I want to understand the full cascade before I agree to the first step. Question 3. What are the procedural risks specific to me, accounting for my age, my current medications, and my overall health status? Question 4. Is there an evidence-based alternative to this screening or its likely follow-up that I should understand before we proceed? Question 5. Does the U.S. Preventive Services Task Force, the American Geriatric Society, or any relevant specialty organization have guidance about whether this test is recommended for someone my age specifically? Any physician practicing evidence-based, patient-centered medicine will welcome these questions, not as a challenge to their competence, as an invitation to a better conversation. And if the response is dismissive of questions this reasonable, that is information worth having about your care. Here is your 30-day action step. Before your next scheduled appointment, write down every screening test you have had in the past 3 years. For each one, note how old you were when you first started having it, and whether anyone has ever had a specific, individualized conversation with you about whether it still makes sense for your age and current health. Bring that list to your next appointment with one sentence ready: I want to make sure the tests I'm having are still the right tests for where I am now. That sentence does not challenge anyone. It invites collaboration. And in 30 days, you will have had at least one conversation about your health care that did not happen automatically, one that you initiated on your terms with the right questions in hand. There is a difference between medicine that screens for everything that can be found and medicine that focuses on what will actually improve your quality and length of life. After 70, those two things diverge in ways that most patients, and frankly many physicians working under time pressure, do not fully appreciate in the moment. The best doctors I have known over 21 years are not the ones who ordered the most tests. They are the ones who asked the most careful questions. Who understood that a finding is only valuable when acting on it makes a patient's life genuinely better. Who had the intellectual confidence to say, for you specifically at this point in your life, this test is worth doing, or this one isn't? That is the medicine that serves people well after 70. And now you have the framework and the questions to help bring that medicine into your own care. You are not a checklist. You are a person with a specific history, specific goals, and specific priorities. And the health care you receive should reflect all three. In 21 years, I have watched patients who ask better questions receive better care. Not because they were difficult, because the questions created space for the right conversation, and that space is yours to create. If this gave you something useful, subscribe. That is what this channel is built for: calm, evidence-based guidance for adults who want to understand their health care, not just receive it. I'll see you in the next one.